welcome everyone from me as well. In the next 20 minutes, I will give you an overview of the current knowledge on somatosensory tinnitus. If I can go here. Just to be sure that we're all talking about the same thing, I would like to start by defining what type of tinnitus I will be discussing. So we call tinnitus somatic or somatosensory in case altered input from the somatosensory system of the cervical spine or the jaw area influences the tinnitus. In most cases, patients have a separate primary cause for their tinnitus, often related to some age-related hearing loss, for instance, but their tinnitus changes in loudness or pitch due to neck or joint dysfunctions. In some rare cases, the input from the cervical spine or the orofacial somatosensory system can also really cause a tinnitus. And that's what I'm going to talk about. Now, neurophysiologically, somatosensory tinnitus is explained by neural connections in the brainstem, and that's what we are looking at now. So as you can see in the figure, incoming information from the lower cranial nerves and from the dorsal root of C2 congregate in the medullary somatosensory nuclei. These nuclei are not only connected to the somatosensory cortex, but also to the dorsal cochlear nucleus, which is an important auditory nucleus that regulates incoming information from the auditory system. Now, the connections between the somatosensory nuclei and the cochlear nucleus make sure that you can, for instance, not hear yourself chewing, for those of you who are having lunch during this presentation. But in some people, activity in these connecting fibers can also cause a disinhibition of the dorsal cochlear nucleus, which increases the spontaneous firing rate, and thus more spontaneous activity is then transferred to the auditory cortex, which is perceived by the patient by a change in tinnitus loudness. Now, this system explains why tinnitus can be altered, for instance, by increased muscle tension in the masticatory muscles due to bruxism. Now, because tinnitus often has a multifactorial origin, and because tinnitus and neck or jaw dysfunction can also coexist without influencing each other, diagnosing somatosensory tinnitus is not as easy as it might seem. So through the years, many criteria have been used to include patients with somatosensory tinnitus in studies. And these criteria vary from simply coexisting symptoms of jaw pain and tinnitus, for instance, to patients being able to change their tinnitus during a set of very specific physical tests. Now, these different criteria that were used in studies is of course not very convenient to start comparing different results. And that's why we started a Delphi study in 2016 to reach a consensus on how to identify patients with somatic tinnitus. Now, at that point, we were able to identify 18 somatic tinnitus experts in 10 different countries, and we contacted them all to participate in the Delphi study. 13 of them in the end completed both rounds of the Delphi process, and they were all invited to a face-to-face consensus meeting to agree on a set of diagnostic criteria. Now, the first thing we agreed on during this consensus meeting was that we were not defining somatosensory tinnitus as a completely separate type of tinnitus, but as an influencing factor that can be present alone or in combination with other influencing factors such as hearing loss, but also stress and anxiety and maybe some noise trauma. Now, the Delphi process in the end led to a set of 16 criteria that, when they are present, suggest a somatosensory influence on the tinnitus. Now, we're just going to look at the criteria briefly. I'm not going to read them all out loud. That's something that you can look up. But a first cluster of criteria is about the patient's ability to modulate the tinnitus during voluntary movements of the neck, the jaw, or the eyes. Now, apart from modulation, which means that the tinnitus goes up or down during these movements, modulation can also be present during specific physical testing, such as traction of the jaw joint, as you can see on this picture, or by pressure on myofascial trigger points. So that's one cluster of criteria. A second cluster of criteria describes some tinnitus characteristics that are often present in patients with somatosensory influence on their tinnitus. For instance, neck or jaw complaints and tinnitus that started at the same time or increase and decrease simultaneously are very typical for our patients with somatosensory tinnitus. And also the presence of a head or a neck trauma preceding the start of the tinnitus complaints can be an indication for somatosensory tinnitus. Additionally, the experts agreed that variation in tinnitus pitch, tinnitus loudness, or location of the tinnitus is frequently present in patients with somatosensory tinnitus, at least more than in patients with other types of tinnitus. Then we finally have a third cluster of criteria, and these are symptoms that can accompany the tinnitus, such as neck pain, for instance, but also bruxism, so clenching the teeth or really grinding the teeth, but also jaw pain, and also dental changes, such as a recent start of an orthodontic treatment, but also the use of a new set of false teeth. Now, since we agreed on these criteria, I have been using them myself in the clinic, and I presented them to colleagues at many occasions. But doing so, I realized that it still requires a lot of expertise also on tinnitus in general and on other influencing factors of tinnitus to be able to identify those patients who have this real somatosensory influence on their tinnitus. And that is why we further investigated these criteria to see if some criteria are maybe stronger than others, and to try to make a smaller cluster of criteria that can simplify somatosensory tinnitus diagnosis. Now, for this study, we collaborated with Tinnitus Hub to get as many people with tinnitus as possible to complete our online survey. And in total, we were able to use the data of 7,981 patients, giant group, of which 26% were diagnosed with somatosensory tinnitus by their own physician. Now, we first used these data to investigate the diagnostic value of our 16 criteria separately. And if we look into detail at these figures, we can see that 3 criteria are especially interesting to look at when they are present in your tinnitus patients. So the strongest one is the simultaneous increase and decrease of tinnitus and neck or jaw pain. If that criterion is present, your patient is almost 11 times more likely to have a somatosensory influence on the tinnitus than when it is absent. But also simultaneous onset of tinnitus and neck or jaw pain and the influence of certain postures on the tinnitus are important criteria to keep in mind. Now, on the other hand, there are also 2 criteria that are more important to rule out a somatosensory influence in case they are absent. So the first one is the absence of tension in the neck extensor muscles, which means those are the muscles located in the back of your neck. When there is no tension at all in these muscles, it is very unlikely that a patient has somatosensory influence on the tinnitus. Also, the complete absence of neck pain should make you doubt a somatosensory influence on the tinnitus. Now, apart from looking at the different criteria separately, we also wanted to make a cluster of criteria that would enable us to recognize patients with somatosensory tinnitus more easily and with more certainty. And therefore, we created this decision tree that we called the rapid screening tool for somatosensory tinnitus. And I know it is small, but I will walk you through it in the next slides and enlarge a few things for you. So when you're using the RUST tool, first of all, it is important to know if your patient, apart from his tinnitus, also has neck or jaw complaints. So if they don't, it is very unlikely that there will be a large somatosensory influence on the tinnitus. When they do have neck or jaw complaints, the first thing to ask is whether their pain complaints increase or decrease simultaneously with their tinnitus. So that means that when the pain is worse, tinnitus is worse as well. When the pain is better, tinnitus gets better as well. When this is certainly never the case, somatosensory tinnitus is very unlikely, or somatic influence on the tinnitus is very unlikely. When this co-variation is present, at least some days, you can already be 84% sure that there is a somatosensory influence on the tinnitus. And we will look at, have a look at this branch of our tree first in the next slide. So when you want to look a little bit further, you can ask your patient if he or she experiences some tension in the neck muscles just underneath their skull. That's what the suboccipital muscles mean. In case the patient notices that this tension is there very frequently, you are even more sure of your somatic tinnitus diagnosis. When this muscle tension is absent or only present on occasions, we are only 61% sure anymore about the diagnosis, and we have to look a little bit further. And that's what we will do in the next slide. So we are then looking back at the answer on our first question. And in case there is co-variation of tinnitus and neck or jaw complaints very regularly, you can still be sure about your somatic tinnitus diagnosis. In case this symptom is only present at some occasions, we can ask our patient if they clench or grind their teeth. And when they most certainly do not have bruxism, we can be sure that there is little somatosensory influence on this patient's tinnitus. When they do grind or clench their teeth or are not really sure about it, we can still be a 60% sure about a somatosensory influence on this patient's tinnitus. Now that's one branch of the tree. Let's now go back to our first question so we can have a look at the other branch of the decision tree. There where our patient was not really sure about the simultaneous increase or decrease of their tinnitus and pain complaints, which is something I have to say that happens quite often, that people don't really know if there is for sure a simultaneous increase or decrease. So then we will look further. And we will look again at the tension of the muscles just below the skull. If there is no tension at all, or only occasionally, the somatosensory influence on the tinnitus will be low. And when, on the other hand, there is tension in the suboccipital muscles most of the time, we can be a 56% sure about the somatosensory influence on the tinnitus. Now, in that case, to be a bit more sure, we want to look at the patient's ability to modulate their tinnitus through voluntary movements or pressure on certain areas of the head or the neck. Now, in case a patient can modulate his tinnitus, we can be 66% sure about our somatic tinnitus diagnosis. When they cannot, the chance of having a real somatosensory tinnitus decreases to 35%. And so we are here again looking at the entire flowchart. Now that I've talked about recent developments on somatic tinnitus diagnosis, I would like to continue with a short overview of treatment options for these patients. Our first treatment option for somatic tinnitus is musculoskeletal treatment. That's also the type of treatment that I, as a physiotherapist, apply. And this is the type of treatment that has been investigated the most. And we see really nice results on patients' tinnitus complaints. Now, for the cervical spine, this treatment consists of a combination of manual mobilizations done by the physiotherapist or manipulation sometimes, but also exercises for the cervical spine and trigger point treatment, where we're going to treat the muscles by pressing on certain locations in the muscle. For patients with jaw-related somatic tinnitus, the treatment will be a combination again of mobilizations, but now of the jaw joints. Also exercises for the jaw, trigger point treatment now of the masticatory muscles. Also some counseling to decrease bruxism and other oral parafunctions, such as biting your nails, for instance. And if necessary, we also use occlusal splints. Now, because temporomandibular dysfunctions often occur in combination with neck dysfunction, it is always a good idea to investigate if some of the neck treatment modalities also need to be added to the jaw treatments. Now, as you can see, in musculoskeletal treatment, there is no one-size-fits-all approach. But the content of the treatment needs to be tailored to the specific neck or jaw dysfunctions that are present in your patient to get the best result of your treatment. Now, during my PhD, I investigated the effect of this type of musculoskeletal treatment directed to the cervical spine. And results showed that the TFI scores, so tinnitus functional index scores, significantly decreased after this type of treatment, where they didn't after a similar period of wait and see. Now, patients who responded best to this type of treatment in our study were those who experienced a covariation between neck pain complaints and tinnitus. Again, also, patients who noticed that their tinnitus changed during certain postures, and strangely, patients with a low-pitched tinnitus. Now, one of my former PhD students who defended her PhD last year continued this work and investigated the musculoskeletal treatment now directed at the temporomandibular area in her study, and she found as well that TFI scores significantly decreased after this type of treatment, where they didn't after a similar period of wait and see. In this study, patients who responded best to the TMD treatment were younger females with a more recent onset of their tinnitus complaints. Now also, Cote and colleagues investigated a similar program, and they found that it was effective in decreasing tinnitus severity, especially in patients presenting with somatosensory tinnitus in combination with some specific clinical characteristics. Now, patients who were most likely to improve after treatment in this study were those who experienced no increase of tinnitus when exposed to noise, those who did not have a family history of tinnitus, patients who experienced somatic modulation during specific testing, and patients who had a recent onset of their tinnitus. And then I have a last study I want to point out, the one of Delgado and colleagues, that showed for the jaw treatment, which is interesting, that adding manual mobilizations to the treatment might be necessary to maximize the treatment effect. Now, apart from the musculoskeletal treatment, there are also other treatments that have been investigated for somatic tinnitus, but because they are only based on 1 or 2 studies, I have called them experimental therapies. Now, you will see that not all of them are really experimental for tinnitus, but the first one was a case study where we saw that a cervical collar application can help decrease tinnitus, but of course, because it's just one case study, further investigation is needed in larger groups to really recommend this kind of treatment. Now, a second one was the use of TRT in patients with somatic tinnitus. Of course, TRT is not an experimental treatment, but there is only one study investigating it specifically in a group of patients with somatic tinnitus. And the study of Osterman and colleagues showed good results of this approach also in this group of patients. Then I found two studies investigating the effect of injections on tinnitus complaints. McCormick used a cervical epidural injection in one patient, so that's another case study, with good results. And Stidham used Botox injections in 26 patients, and they saw an improvement in 7 of these 26 patients. So that's not really clear if that is really applicable in a large group. And then finally, there is the study of Marks and colleagues using bimodal stimulation in a specific group of patients with somatic tinnitus. I'm not going to talk a lot about that study because that brings us fluently, I believe, to the next presentation, who will explain certainly more about bimodal stimulation in general. So thanks a lot.